Cataract surgery is the removal of the natural lens of the eye, also called crystalline lens, that has developed an opacification, which is referred to as a cataract. Metabolic changes of the crystalline lens fibers over time lead to the development of the cataract and loss of transparency, causing impairment or loss of vision. In addition to these age-related changes, infants may be born with congenital cataracts. Direct ocular trauma and some medications, specifically the long-term use of steroids, may also result in cataract formation. Long-term exposure to infrared light and microwave radiation may also lead to cataract formation. Many people's first symptoms are strong glare from lights and small light sources at night, along with reduced acuity at low light levels. During cataract surgery, a patient's cloudy natural cataract lens is removed and replaced with a synthetic lens to restore the lens's transparency. Following surgical removal of the natural lens, an artificial intraocular lens implant is inserted. Eye surgeons say that the lens is implanted. Cataract surgery is generally performed by an ophthalmologist in an ambulatory setting rather than an inpatient setting, in a surgical center or hospital. Either topical, peribulbar, or retrobulbar local anesthesia is used, usually causing little or no discomfort to the patient. Well over 90% of operations are successful in restoring useful vision, with a low complication rate. Day care, high volume, minimally invasive, small incision phacoemulsification with quick post-OP recovery has become the standard of care in cataract surgery all over the world. Types. Two main types of surgical procedures are in common use throughout the world. The first procedure is phacoemulsification, phaco, and the second involves two different types of extracapsular cataract extraction, EYNTK. In most surgeries an intraocular lens is inserted. Foldable lenses are generally used for the 2 to 3 mm phaco incision, while non-foldable lenses are placed through the larger extracapsular incision. The small incision size used in phacoemulsification, 2 to 3 mm, often allows sutureless incision closure. EYNTK utilizes a larger incision, 10 to 12 mm, and therefore usually requires stitching, and this in part led to the modification of EYNTK known as manual small incision cataract surgery, MISX. Cataract extraction using intracapsular cataract extraction, ICCE, has been superseded by phaco and EYNTK, and is rarely performed. Phacoemulsification is the most commonly performed cataract procedure in the developed world. However, the high cost of a phacoemulsification machine and of the associated disposable equipment means that EYNTK and MISX remain the most commonly performed procedure in developing countries. Types of surgery. There are a number of different surgical techniques used in cataract surgery. Phacoemulsification, phaco, is the most common technique used in developed countries. It involves the use of a machine with an ultrasonic handpiece equipped with a titanium or steel tip. The tip vibrates at ultrasonic frequency, 40,000 Hz, and the lens material is emulsified. A second fine instrument, sometimes called a cracker or chopper, may be used from a side port to facilitate cracking or chopping of the nucleus into smaller pieces. Fragmentation into smaller pieces makes emulsification easier, as well as the aspiration of cortical material, soft part of the lens around the nucleus. After phacoemulsification of the lens nucleus and cortical material is completed, a dual irrigation aspiration, IA, probe or a bimanual IA system is used to aspirate out the remaining peripheral cortical material. Manual small incision cataract surgery, MISX. This technique is an evolution of EYNTK, see below, where the entire lens is expressed out of the eye through a self-sealing scleral tunnel wound. An appropriately constructed scleral tunnel is watertight and does not require suturing. The small in the title refers to the wound being relatively smaller than an EYNTK, although it is still markedly larger than a phaco wound. Head-to-head trials of MISX vs phaco in dense cataracts have found no difference in outcomes, but shorter operating time and significantly lower costs with MISX. Extracapsular cataract extraction. EYNTK extracapsular cataract extraction involves the removal of almost the entire natural lens while the elastic lens capsule, posterior capsule, is left intact to allow implantation of an intraocular lens. It involves manual expression of the lens through a large, usually 10-12 mm, incision made in the cornea or sclera. Although it requires a larger incision and the use of stitches, the conventional method may be indicated for patients with very hard cataracts or other situations in which phacoemulsification is problematic. Intracapsular cataract extraction, ICCE, involves the removal of the lens and the surrounding lens capsule in one piece. The procedure has a relatively high rate of complications due to the large incision required and pressure placed on the vitreous body. It has therefore been largely superseded and is rarely performed in countries where operating microscopes and high-technology equipment are readily available. After lens removal, an artificial plastic lens, an intraocular lens implant, can be placed in either the anterior chamber or sutured into the sulcus. Femtosecond laser appears safe but has few benefits over phacoemulsification. Cryoextraction is a form of ICCE that freezes the lens with a cryogenic substance such as liquid nitrogen. In this technique, the cataract is extracted through use of a cryoextractor, a cryoprobe whose refrigerated tip adheres to and freezes tissue of the lens, permitting its removal. Although it is now used primarily for the removal of subluxated lenses, it was the favored form of cataract extraction from the late 1960s to the early 1980s. Intraocular lenses. Intraocular lens implantation. After the removal of the cataract, an intraocular lens, IOL, is usually implanted into the eye, either through a small incision, 1.8 mm to 2.8 mm, using a foldable IOL, or through an enlarged incision, using a PMMA, polymethyl methacrylate, lens. The foldable IOL, made of silicone or acrylic material of appropriate power, is folded either using a holder/folder, or a proprietary insertion device provided along with the IOL. The lens implanted is inserted through the incision into the capsular bag within the posterior chamber, in the bag implantation. Sometimes, a sulcus implantation, in front or on top of the capsular bag but behind the iris, may be required because of posterior capsular tears or because of zonulodialysis. Implantation of posterior chamber IOL, PCOL, in patients below 1 year of age is controversial due to rapid ocular growth at this age and the excessive amount of inflammation, which may be very difficult to control. Optical correction in these patients without intraocular lens, a phakic, is usually managed with either special contact lenses or glasses. Secondary implantation of IOL, placement of a lens implant as a second operation, may be considered later. New designs of multifocal intraocular lens are now available. These lenses allow focusing of rays from distant as well as near objects, working much like bifocal or trifocal eyeglasses. Preoperative patient selection and good counseling is extremely important to avoid unrealistic expectations and postoperative patient dissatisfaction. Acceptability for these lenses has become better and studies have shown good results in selected patients. In addition, there is an accommodating lens that was approved by the US FDA in 2003 and made by EYNTK, now Bausch & Lomb. The Crystal lens is on struts and is implanted in the eye's lens capsule, and its design allows the lens focusing muscles to move it back and forth, giving the patient natural focusing ability. Artificial intraocular lenses are used to replace the eye's natural lens that is removed during cataract surgery. These lenses have been increasing in popularity since the 1960s, but it was not until 1981 that the first U.S. Food and Drug Administration, FDA, approval for this type of product was issued. The development of intraocular lenses brought about an innovation as patients previously did not have their natural lens replaced and as a result had to wear very thick eyeglasses or some special type of contact lenses. Presently, IOLs are especially designed for patients with different vision problems. The main types of IOLs that now exist are divided into monofocal and multifocal lenses. The monofocal intraocular lenses are the traditional ones, which may provide vision at one distance only, far, intermediate, or near. Patients who choose these lenses over the more developed types will have to overcome the disadvantage of wearing eyeglasses or contact lenses for reading or using the computer. These intraocular lenses are usually spherical, and they have their surface uniformly curved. The multifocal intraocular lens is one of the newest types of such lenses. They are often referred to as premium lenses because they are multifocal and accommodative and allow the patient to visualize objects at more than one distance, removing the need to wear eyeglasses or contact lenses. Premium intraocular lenses are those used in correcting presbyopia or astigmatism. Premium intraocular lenses are typically not covered by insurance companies as their additional benefits are considered a luxury and not a medical necessity. An accommodative intraocular lens implant has only one focal point, but it acts as if it is a multifocal IOL. The intraocular lens was designed with a hinge similar to the mechanics of the eye's natural lens. The intraocular lenses used in correcting astigmatism are called toric and have been FDA approved since 1998. The STAR surgical intraocular lens was the first such lens ever developed in the United States, and it may correct up to 3.5 diopters. A different model of toric lenses is created by Alcon and may correct up to 3 diopters of astigmatism. In order to achieve the most benefit from a toric lens, the surgeon must rotate the lens to be on axis with the patient's astigmatism. Intraoperative wavefront analysis, such as that provided by the Aura system developed by EYNTK Vision Systems, can be used to assist the doctor in toric lens placement and minimize astigmatic errors. Cataract surgery may be performed to correct vision problems in both eyes, and in these cases, patients are usually advised to consider monovision. This procedure involves inserting in one eye an intraocular lens that provides near vision and in the other eye an IOL that provides distance vision. Although most patients can adjust to having implanted monofocal lenses in both eyes, some cannot and may experience blurred vision at both near and far distances. IOLs that emphasize distance vision may be mixed with IOLs that emphasize intermediate vision in order to achieve a type of modified monovision. Bosch and Lomb developed in 2004 the first aspheric IOLs, which provide better contrast sensitivity by having their periphery flatter than the middle of the lens. However, some cataract surgeons have debated the benefits of aspheric IOLs, because the contrast sensitivity benefit may not last in older patients. Some of the newly launched IOLs are able to provide ultraviolet and blue light protection. The crystalline lens of the eye filters these potentially harmful rays, and many premium IOLs are designed to undertake this task as well. According to a few studies though, these lenses have been associated with a decrease in vision quality. Another type of intraocular lenses is the light-adjustable one, which is still undergoing FDA clinical trials. This particular type of IOL is implanted in the eye and then treated with light of a certain wavelength in order to alter the curvature of the lens. In some cases, surgeons may opt for inserting an additional lens over the already implanted one. This type of IOLs procedures are called piggyback IOLs and are usually considered an option whenever the lens result of the first implant is not optimal. In such cases, implanting another IOL over the existent one is considered safer than replacing the initial lens. This approach may also be used in patients who need high degrees of vision correction. No matter which IOL is used, the surgeon will need to select the appropriate power of IOL, much like an eyeglass prescription, to provide the patient with the desired refractive outcome. Traditionally, doctors use preoperative measurements including corneal curvature, axial length, and white-to-white measurements to estimate the required power of the IOL. These traditional methods include several formulas including Hages, Hoffer Q, Holiday 1, Holiday 2, and SRK/T to name a few. Refractive results using traditional power calculation formulas leave patients within 0.5 d of target, correlates to 20/25 when targeted for distance, or better in 55% of cases, and within 1 d, correlates to 20/40 when targeted for distance, or better in 85% of cases. Recent developments in interoperative wavefront technology such as the Aura system from EYNTK Vision Systems, have demonstrated in studies, power calculations that provide improved outcomes, yielding 80% of patients within 0.5 d, 20/25 or better. Statistically, cataract surgery and IOL implantation seem to be procedures with the safest and highest success rates when it comes to eye care. However, as with any other type of surgery, it implies certain risks. The cost is another important aspect of these lenses. Although most insurance companies cover the costs of traditional IOLs, patients may need to pay the price difference in case they choose more advanced lenses, such as the premium ones. Preoperative evaluation. An eye examination or preoperative evaluation by an eye surgeon is necessary to confirm the presence of a cataract and to determine if the patient is a suitable candidate for surgery. The patient must fulfill certain requirements such as the degree of reduction of vision due, at least in large part, to the cataract should be evaluated. While the existence of other sight-threatening diseases, such as age-related macular degeneration or glaucoma, does not preclude cataract surgery, less improvement may be expected in their presence. The eyes should have a normal pressure, or any pre-existing glaucoma should be adequately controlled with medications. In cases of uncontrolled glaucoma, a combined cataract glaucoma procedure, phocotrabeculectomy, can be planned and performed. The pupil should be adequately dilated using eye drops. If pharmacologic pupil dilation is inadequate, procedures for mechanical pupillary dilatation may be needed during the surgery. The patients with retinal detachment may be scheduled for a combined vitreoretinal procedure, along with PCIOL implantation. In addition, it has recently been shown that patients taking tamsulosin, Flomax, a common drug for enlarged prostate, are prone to developing a surgical complication known as intraoperative floppy iris syndrome, IFIS, which must be correctly managed to avoid the complication posterior capsule rupture. However, prospective studies have shown that the risk is greatly reduced if the surgeon is informed of the patient's history with the drug beforehand, and has appropriate alternative techniques prepared. A Cochrane review of 3 randomized clinical trials including over 21,500 cataract surgeries examined whether routine preoperative medical testing resulted in a reduction of adverse events during surgery. Results showed that performing preoperative medical testing did not result in a reduction of risk of intraoperative or postoperative medical adverse events, compared to surgeries with no or limited preoperative testing. Operation procedures. The surgical procedure in phacoemulsification for removal of cataract involves a number of steps. Each step must be carefully and skillfully performed in order to achieve the desired result. The steps may be described as follows. Anesthesia. Exposure of the eyeball using an eyelid speculum. Entry into the eye through a minimal incision, corneal or scleral. Viscoelastic injection to stabilize the anterior chamber and to help maintain the eye pressurization. Capsulorhexis. Hydrodissection pi. Hydrodelineation. Ultrasonic destruction or emulsification of the cataract after nuclear cracking or chopping, if needed, careful aspiration of the remaining lens cortex, outer layer of lens, material from the capsular bag, capsular polishing, if needed. Implantation of the, usually foldable, intraocular lens, IOL. Viscoelastic removal. Wound sealing/hydration, if needed. The pupil is dilated using drops, if the IOL is to be placed behind the iris, to help better visualize the cataract. Pupil constricting drops are reserved for secondary implantation of the IOL in front of the iris, if the cataract has already been removed without primary IOL implantation. Anesthesia may be placed topically, eye drops, or via injection next to, peribulbar, or behind, retrobulbar, the eye. Oral or intravenous sedation may also be used to reduce anxiety. General anesthesia is rarely necessary, but may be employed for children and adults with particular medical or psychiatric issues. The operation may occur on a stretcher or a reclining examination chair. The eyelids and surrounding skin will be swabbed with disinfectant. The face is covered with a cloth or sheet, with an opening for the operative eye. The eyelid is held open with a speculum to minimize blinking during surgery. Pain is usually minimal in properly anesthetized eyes, though a pressure sensation and discomfort from the bright operating microscope light is common. The ocular surface is kept moist using sterile saline eye drops or methylcellulose viscoelastic. The discussion into the lens of the eye is performed at or near where the cornea and sclerum meet, limbus equals corneoscleral junction. Advantages of the smaller incision include use of few or no stitches and shortened recovery time. A capsulotomy, rarely known as cystotomy, is a procedure to open a portion of the lens capsule, using an instrument called a cystotomy. An anterior capsulotomy refers to the opening of the front portion of the lens capsule, whereas a posterior capsulotomy refers to the opening of the back portion of the lens capsule. In phacoemulsification, the surgeon performs an anterior continuous curvilinear capsulorhexis, to create a round and smooth opening through which the lens nucleus can be emulsified and the intraocular lens implant inserted. Following cataract removal, via ECI or phacoemulsification, as described above, an intraocular lens is usually inserted. After the IOL is inserted, the surgeon checks that the incision does not leak fluid. This is a very important step, since wound leakage increases the risk of unwanted microorganisms gaining access into the eye and predispose to endophthalmitis. An antibiotic/steroid combination eye drop is put in and an eye shield may be applied on the operated eye, sometimes supplemented with an eye patch. Antibiotics may be administered preoperatively, intraoperatively, and/or postoperatively. Frequently a topical corticosteroid is used in combination with topical antibiotics postoperatively. Most cataract operations are performed under a local anesthetic, allowing the patient to go home the same day. The use of an eye patch may be indicated, usually for about some hours, after which the patient is instructed to start using the eye drops to control the inflammation and the antibiotics that prevent infection. Lens and cataract procedures are commonly done in an outpatient setting. In the United States, 99.9% of lens and cataract procedures were done in an ambulatory setting in 2012. Occasionally, a peripheral iridectomy may be performed to minimize the risk of pupillary block glaucoma. An opening through the iris can be fashioned manually, surgical iridectomy, or with a laser, called Nd:YAG laser iridotomy. The laser peripheral iridotomy may be performed either prior to or following cataract surgery. The iridectomy hole is larger when done manually than when performed with a laser. When the manual surgical procedure is performed, some negative side effects may occur, such as that the opening of the iris can be seen by others, aesthetics, and the light can fall into the eye through the new hole, creating some visual disturbances. In the case of visual disturbances, the eye and brain often learn to compensate and ignore the disturbances over a couple of months. Sometimes the peripheral iris opening can heal, which means that the hole ceases to exist. This is the reason that the surgeon sometimes makes two holes, so that at least one hole is kept open. After the surgery, the patient is instructed to use anti-inflammatory and antibiotic eye drops for up to 2 weeks, depending on the inflammation status of the eye and some other variables. The eye surgeon will judge, based on each patient's idiosyncrasies, the time length to use the eye drops. The eye will be mostly recovered within a week, and complete recovery should be expected in about a month. The patient should not participate in contact/extreme sports until cleared to do so by the eye surgeon. Complications. Complications after cataract surgery are relatively uncommon. PVD posterior vitreous detachment does not directly threaten vision. Even so, it is of increasing interest because the interaction between the vitreous body and the retina might play a decisive role in the development of major pathologic vitreoretinal conditions. PVD may be more problematic with younger patients, since many patients older than 60 have already gone through PVD. PVD may be accompanied by peripheral light flashes and increasing numbers of floaters. PCO. Some people can develop a posterior capsular opacification, PCO, also called an after cataract. As a physiological change expected after cataract surgery, the posterior capsular cells undergo hyperplasia and cellular migration, showing up as a thickening, opacification, and clouding of the posterior lens capsule, which is left behind when the cataract was removed, for placement of the IOL. This may compromise visual acuity and the ophthalmologist can use a device to correct this situation. It can be safely and painlessly corrected using a laser device to make small holes in the posterior lens capsule of the crystalline. It usually is a quick outpatient procedure that uses a Nd:YAG laser, neodymium yttrium aluminum garnet, to disrupt and clear the central portion of the opacified posterior lens capsule, Posterior capsulotomy. This creates a clear central visual axis for improving visual acuity. In very thick opaque posterior capsules, a surgical, manual, capsulectomy is the surgical procedure performed. A YAG capsulotomy is, however, a factor which must be taken in consideration in the event of IOL replacement, as vitreous can migrate toward the anterior chamber through the opening hitherto occluded by the IOL. Posterior capsular tear may be a complication during cataract surgery. The rate of posterior capsular tear among skilled surgeons is around 2% to 5%. It refers to a rupture of the posterior capsule of the natural lens. Surgical management may involve anterior vitrectomy and, occasionally, alternative planning for implanting the intraocular lens, either in the ciliary sulcus, in the anterior chamber, in front of the iris, or, less commonly, sutured to the sclera. Retinal detachment is an uncommon complication of cataract surgery, which may occur weeks, months, or even years later. Toxic anterior segment syndrome or TAS is a non-infectious inflammatory condition that may occur following cataract surgery. It is usually treated with topical corticosteroids in high dosage and frequency. Endophthalmitis is a serious infection of the intraocular tissues, usually following intraocular surgery, or penetrating trauma. There is some concern that the clear cornea incision might predispose to the increase of endophthalmitis, but there is no conclusive study to corroborate this suspicion. Glaucoma may occur and it may be very difficult to control. It is usually associated with inflammation, especially when little fragments or chunks of the nucleus get access to the vitreous cavity. Some experts recommend early intervention when this condition happens, posterior pars plana vitrectomy. Neovascular glaucoma may occur, especially in diabetic patients. In some patients, the intraocular pressure may remain so high that blindness may ensue. Swelling or edema of the central part of the retina, called macula, resulting in macular edema, can occur a few days or weeks after surgery. Most such cases can be successfully treated. Preventative use of nonsteroidal anti-inflammatory drugs has been reported to reduce the risk of macular edema to some extent. Other possible complications include swelling or edema of the cornea, sometimes associated with cloudy vision, which may be transient or permanent, pseudophakic bullous keratopathy. Displacement or dislocation of the intraocular lens implant may rarely occur. Unplanned high refractive error, either myopic or hypermetropic, may occur due to error in the ultrasonic biometry, measure of the length and the required intraocular lens power. Cyanopsia, in which the patient sees everything tinted with blue, often occurs for a few days, weeks, or months after removal of a cataract. Floaters commonly appear after surgery. History. Ancient Greece. Galen of Pergamon, ca 2nd century CE, a prominent Greek physician, surgeon, and philosopher, performed an operation similar to modern cataract surgery. Using a needle-shaped instrument, Galen attempted to remove a cataract-affected lens. His surgical experiments included ligating the arteries of living animals. Although many 20th century historians have claimed that Galen believed the lens to be in the exact center of the eye, Galen actually understood that the crystalline lens is located in the anterior aspect of the human eye. India. A form of cataract surgery, now known as couching, was found in ancient India and subsequently introduced to other countries by the Indian physician Sushruta, ca 3rd century CE, who described it in his work The Compendium of Sushruta or Sushruta Samhita. The Uttaratantra section of the compendium, chapter 17, verses 55-69, describes an operation in which a curved needle was used to push the opaque phlegmatic matter, kapha in Sanskrit, in the eye out of the way of vision. The phlegm was then blown out of the nose. The eye would later be soaked with warm clarified butter and then bandaged. Here is translation from the original Sanskrit. Verses 55-56, now procedure of surgical operation of lamika ligana, cataract, will be described. It should be taken up, for treatment, if the diseased portion in the pupillary region is not shaped like half moon, sweat drop, or pearl, not fixed, uneven and thin in the center, streaked or variegated and is not found painful or reddish. Verses 57-61 IB. In moderate season, after unction and sudation, the patient should be positioned and held firmly while gazing at his nose steadily. Now the wise surgeon, leaving 2 parts of white circle from the black one towards the outer canthus, should open his eyes properly free from vascular network, and then with a barley-tipped rod-like instrument held firmly in hand with middle, index, and thumb fingers should puncture the natural hole-like point with effort and confidence, not below, above or in sides. The left eye should be punctured with right hand and vice versa. When punctured properly, a drop of fluid comes out and also there is some typical sound. Verses 61b-c 64ab. Just after puncturing, the expert should irrigate the eye with breast milk and foment it from outside with vita alleviating tender leaves, irrespective of DOA being stable or mobile, holding the instrument properly in position. Then the pupillary circle should be scraped with the tip of the instrument while the patient, closing the nostril of the side opposite to the punctured eye, should blow so that cough located in the region be eliminated. Verses 64-67. When pupillary region becomes clear like cloudless sun and is painless, it should be considered as scraped properly. If DOA can't be eliminated or it reappears, puncturing is repeated after unction and sudation. When the sites are seen properly, the alk should be removed slowly, eye anointed with ghee and bandaged. Then the patient should lie down in supine position in a peaceful chamber. He should avoid belching, coughing, sneezing, spitting and shaking during the operation, and thereafter should observe the restrictions as after intake of snuha. V.68. Eye should be washed with vita alleviating decoctions after every 3 days, and to eliminate fear of aggravation of vayu, it should also be fomented as mentioned before, from outside and mildly. V.69. After observing restrictions for 10 days in this way, post-operative measures to normalize vision should be employed along with light diet in proper quantity. The removal of cataract by surgery was also introduced into China from India, and flourished in the Sui, AD 581-618, and Tang dynasties, AD 618-907. Europe and the Islamic world. The first references to cataract and its treatment in Europe are found in 29 AD in Decompression, the work of T.
Please subscribe and thanks for watching.